was mainly David Gray, that a colleague of ours, a professor from Aberdeen and Birmingham, who sort of said to us that we really perhaps needed to relook at debridement, because we've looked at lots of things in wound care, and obviously we've heard from John how important debridement is, but when we look at our own clinical practice in the UK, had we really revisited debridement in a while, or had it become sort of ritualistic practice within wound care, and we need to perhaps go back and revisit that. So that's what we did, and we produced that consensus document. Since then, I have been involved with the European Wound Management Association, and in a parallel initiative, they have wanted to produce a document about best practice guidance for debridement. So I just want to take you quickly through what my role has been in that and what the latest thinking from the European Wound Management Association is about debridement. And this document is to be launched later on this year. So the gentleman that started the initiative was Robert Strohal, and Robert is a dermatologist from Vienna. And then there was a group of us pulled together, and I'm not quite sure why or the rationale for putting the group together, but we ended up being assembled, and you can see the people there on the slide. Julie Jordan O'Brien is a nurse from Ireland and a nurse lecturer. Joaquin Dissamond is a medic from Germany. Myself is a wound care nurse, stroke lecturer from Cardiff. And then we had Alberto Piergassi, who's a dermatologist from Italy. The next gentleman is a plastic surgeon from Latvia. Jan Appelvist is the current president of the European Wound Management Association. And we were all allocated chapters, and I was allocated mechanical debridement, which I was quite happy with being allocated mechanical debridement. And it was a bit awful, really, because I did think, well, at mechanical debridement, there's not going to be as many papers to review, so I thought I got quite an easy chapter, which came back to bite me, really, so that teaches me for thinking those kind of things, and I should have been more keen to get on with a lot of work than a little work. So what we did, we produced a debridement algorithm, which I'll share with you after. We looked at the supporting literature, and we also produced a checklist for clinicians to use prior to using any method of debridement to make sure that patient safety was paramount. So the European Wound Management Association paid an individual to search the literature for debridement in those subject areas. They provided us with all the literature, which within your own chapter you had to review the literature and then come up with recommendations for practice. So that's what I had to do for mechanical debridement. The first thing we had to do, though, is we actually had to define what we meant by debridement, because there's a fine line between what is debridement and what is wound cleansing. So for the purpose of this document, that was the definition that you can read up there in front of you. And that was our working definition of debridement. And we needed this because we had to make sure the papers addressed our definition of debridement, because there were a lot of papers that addressed wound cleansing that were falling into that section. So by providing this definition, we knew exactly what papers we were to look at when we were reviewing the literature. The zero crusts. We said that it wasn't a term that we used in the UK, but it's a term that's used in mainland Europe, and that's that dry area in the peri-wound skin when you get the dry edge to a wound bed if it's not been kept moist. So that's what was meant by zero crusts. And we tried to sort of remove it or anglicise it, but the people from mainland Europe said no, it really meant something to them, so the zero crusts stayed in case you thought we just made up new words for the sake of it. So what we had to look at, and we were quite cognizant of these factors here, is that when we were looking at debridement, and this is about the Debridement Revolution, I think, that is quietly taking place, as I say, a response of David Gray's initial work. Because when we said we needed to revisit debridement, we felt that perhaps what was happening is the debridement method we were choosing was not perhaps a result of patient choice. And I would perhaps challenge yourselves, really, how many of you go to your patients and say, we need to debride the wound, and unlike John, these are the different options open to us. Which one would you like? Or do we tend to think, right, these are the debridement skills I have as a nurse, these are the products that are available to me, so that's what we'll use. And is that always the best for the patient? Is it what they need in a timely manner? So we needed to relook at debridement to say, right, let's put the patient back at the top and not our skills or what we can get our hands on in our leg clubs or our clinics. So we really needed to try and challenge the way we thought and worked in the debridement field. So, as I say, I had the mechanical debridement chapter. So I was looking at those things that you can see there. The things that John, which I'm very pleased to hear, said that wet to dry is not acceptable. So that was very good to hear. And that's the things I had to look at. So I thought, well, there won't be much literature on these things. But there was, because as John said, in America, wet to dry is still one of the most common forms of debridement used, which is when you put wet saline gauze on a wound, let it dry out, it embeds itself into the devitalised tissue, and then you rip the rip the gauze away and take the good tissue away, as well as the old tissue, the non-viable tissue. So there were lots and lots and lots of papers on wet to dry. But for me, what their outcome wasn't debridement. Most of them were outcome was to healing. So they would mention debridement, but I would have no facts or figures or statistics then to make a judgment about whether this was an effective method of debridement. So there were lots and lots of papers, but not many with debridement as its outcome. And that I could say for the whole of the mechanical chapter. So there's definitely an issue about research into debridement as a primary outcome of a research study. So they were what I looked at. So this is what my conclusion was about gauze. And I don't think any of you will find this is a great shock. So I don't think in leg clubs we use gauze as a method of debridement. Not that I've seen anyway, and I'm sure we don't. But you can see there that there are problems with gauze. It's not really something we should be going along or recommending as a debridement agent. And it was interesting there about the pain issue relating to debridement. And then I thought of what John was having to do in his situation, and it's quite humbling, isn't it? So with the wet to dry, I wasn't shocked really to find that the literature said that people don't concord with this. You know, and I thought, well, yes, I don't think I'd want to concord with that. You can see that it causes problems then later on with infection. We've got foreign bodies in the wound bed. You can see that we're damaging good tissue. So there were lots of issues there. And I thought that this would be seen as a cheap option. So I thought, oh, it might sort of get some recommendations as a cost-effective method. But actually it wasn't, because you have to do this twice a day. And we're very expensive as clinicians. So even though the gauze is cheap, it actually came out as a costly intervention. Then I looked at paraffin tulle. And there were, again, a few articles, but very few relating to debridement. And you can see there are the same problems with paraffin tulle that there were with the wet to dry. And I would say when John was talking about the frequency of changes of the paraffin tulle dressings, they probably wouldn't get the adherence that we get if we leave it to dry out. So it wasn't really an option for me to recommend as practice. The other one in the chapter was Debridement, and Debridement is outside on the Activa Healthcare stand, and it's a new introduction to us in the UK as a new method of mechanically debriding the wounds. I had papers presented to me on a variety of wound types when it had been used for debridement, and it was seen to be very effective in the removal of the non-viable tissue in the wound bed, and also of the hyperkeratosis that builds upon the surrounding skin in patients with venous leg ulcers. It was seen to be very quick. The papers go from debridement being achieved within 2 to 12 minutes, and sometimes just with one application of Debridement. The pain issue was that there tended to be very little pain. There was the odd report of pain, but on the whole it was seen to be a pain-free procedure. So here within the mechanical chapter, I actually had something that I could recommend as being effective for debridement, which was a good positive outcome. So you can read there what my conclusion was from redoing the chapter on mechanical debridement. There are certain things that perhaps we should not use for the reasons that you saw on the slides, but also we've got new emerging technologies which can help us, and we need more research to make sure we can use them then in their optimum therapeutic way. What the UMA document did do, it provided a debridement cycle. I know you can't see this, and the document, they allowed me to bring this here to you even though it hasn't actually been published yet. So this is You're only the second people to see this outside of the group. But we talk about debridement as a process, not a one-off. And I think this cycle where we look at diagnosis, decision-making, interventions and revisiting our goal, I think will help us in clinical practice to make sure when we are debriding, we really evaluate what we do. We look at what we need to do to get effective debridement, and we can actually close the whole cycle and make sure that we've got a good, smooth, effective therapeutic process. So hopefully this is really going to help us with our practice. The other thing that we have produced, and I apologise, again, I've had to take this from the draft of the document, and I'm aware you can't see it at the back. But what we have here, we talk about here about a time issue. So we've got the least time-consuming methods at the top, and then we've got the most time-consuming methods at the bottom. Because before we used to have a hierarchy of debridement with surgical debridement at the top, but we felt that for our patients to get them admitted, to then get them debrided, and at risk of assessed for anaesthesia, post-operative care, and then back home, it actually wasn't a quick procedure. It was quite a slow procedure to get a patient from home in, debrided and out. So we felt the quickest procedure was mechanical, and what we've put here, you'll be able to read them in the document when it comes out, are the benefits of each method, but also the disadvantages. So we're trying to give a balanced picture here. So we have mechanical, sharp, larval therapy, autolytic or enzymatic, jet lavage or ultrasound, and finally surgical debridement. I know we don't use jet lavage and ultrasound that much at the moment in the UK, but they are emerging technologies. So thank you for your attention, and just a quick update on debridement. Thank you very much.